Hi, good afternoon, ladies and gentlemen. This is great pleasure for me to have the opportunity to facilitate this session. Our topic this afternoon is innovative healthcare models beyond border. And I'm very pleased that we have very three distinguished guests next to me, and then I'm sure we shall have a very good discussion. And to start with, maybe I need to clarify, each of you would have 15 minutes of presentation, and somebody else would give you the signal when you only have 5 minutes left, and remind you that you may have to finish soon. And then after this, we should actually have about 30 to 45 minutes for discussions among us or to receive the questions from the floor. So is that okay? Seven? All right. Okay, so start with, maybe we can start with Matthew, One Job Street. I can see that you have a very interesting experience about encouraging neighborhood mutual care.
Wonderful, thank
Please
you.
do.
Thank you. Thank you so much. I'll stand up and walk around, get some exercise. So this is Vera. She was 101, and when we went to her house, we were the only people that visited her that day. So we really focused on isolation and loneliness, and how if you don't solve isolation and loneliness, then all of the work of the hospital and all of the work of the nurses can fall apart very quickly. If you're isolated and lonely, it's a 40% increase of mortality. So it's absolutely essential. We use Facebook because on Facebook there's a really thick market of social activity. Older people don't need to be on Facebook. In our neighbourhoods in Melbourne, in Australia, there can be up to 1,000 posts a day on Facebook. So for us, we knew this was a thick market of social activity. And this, for Vera, for example, she has such a thin market of social activity. We look at extending the model of care, because the model of care which does not include the community is not going to be sustainable. So for us, it's absolutely essential to think of everyone in the circle and have these well-being kind of frameworks or support networks around an older person. So in England, they asked 50,000 people, do you want to make your suburb a better place? And 60% of them said, yes, we want to make the suburb a better place. When they asked them how many actually do that, only 3% did. So we have a design problem. We haven't designed a participation culture within our suburbs that make it really easy to volunteer. We've made volunteerism an elite sport. So normally what happens when you try and solve for isolation and loneliness or support older people, often people are looking at just a single solution, but the best evidence across the world shows you need to have multiple projects to reduce social isolation and loneliness in older people. So what we do is we map all of the resources in our local neighbourhood and we run many projects. So you really can't say one project will solve one thing. We run a whole lot of projects all at the same time. What that compares to startup culture, and startup culture tend to be really simplistic. So I know there's a startup culture down the back there, but they often look for one single solution, and that won't solve isolation and loneliness in older people. So how do you reduce emergency departments' presentations of older people? You look at the suburb and make it a better place. So in England, they focused on making the suburb a better place, and they reduced the emergency department presentations by 14%. That's the biggest reduction in emergency department presentations for people over 65 with loneliness and isolation. But they did that by creating community orchards, urban farming, batch cooking. They made the suburb a better place to live in. So we do One Good Street. It's micro-ambitious. It just focuses on one street at a time, making the street a better place to be in, and we reward that street for becoming a better place to be in. We use Facebook because many people are on Facebook. We have 500 volunteers and they are willing to do anything for an older person. The older person does not have to use any technology, and we use the community nurses to refer to us. So we have a referral pathway, and we have 500 volunteers that we provide a whole range of things for them to do. Things like this. They can take an older person out for a bike ride who hasn't been in the community. I don't know how you'd go in the streets of Hong Kong with something like that. But what we have to do with our volunteers is provide informal, high-frequency, low-commitment, non-competitive ways for them to help other people. They don't need 3 days training to help an older person. We should just help them do it really naturally. we also host air conditioning clubs in the heat. So in Australia, you know it gets a bit hot, right? So during the times when it's hot, people open up their houses to older people and make sure they're hydrated. The thing here is it stops emergency department presentations, deterioration, and this costs nothing. This is completely free and done in the community. We also find ways to respect older people in our aged care facilities. So we reward each street for doing good work, and the way we do that is on a heat map on our website. If you are a member of One Good Street, your street changes colour. So when you're selling your house on one of these streets, you can highlight the fact that your street is a better place to live in for older people. So there's an economic value for the volunteerism. This is the way we reward that kind of behaviour. That's what the heat map looks like. These are the best streets to live in. So if any of you want to move to Australia, make sure you have a look here and see which street to live in, because these are the best streets to live in. We also provide a library of aged care things, a free lending library of aged care equipment. If you want to live and die in your home, this is the shopping list of everything you need. Your adult children will need to buy that for you at some stage, but it's expensive. And on Facebook, people are giving this stuff away for free. They don't want to sell it. This lady is giving away her hearing aids. This one here has got crutches and moon boots, enough for a whole soccer team. I go to aged care facilities and find equipment like this all the time. So we realised there was a design problem. So we just designed a platform where if you have equipment in your house, it's very easy to give to somebody else. This gentleman waited 3 years for this scooter. 3 years. He had no money to purchase it. I found it in somebody's garage and it had been sitting there for 3 years. So we just had to design a platform for the free exchange of aged care equipment. This lady here got this chair for free as well, and that's the community nurse that referred her to our service. So it's absolutely important that we have an industry partner to help the participation culture. They're in the homes of older people who have no one else in their life. So it's absolutely essential that we join the two together. This is another gentleman with a scooter. I just quickly finish on this. This is the world's first wearable to detect loneliness. So what this does, it counts the number of words an older person speaks. It just looks like a brooch, because we know that older people don't like wearing a lot of tech, and that about 40% of them don't even wear their own hearing aids. So we designed a wearable that counts the number of words an older person speaks. If it drops below 50 words per day, an SMS is sent to family, friends, or a volunteer phone service, or a volunteer visitor service. You and I speak 20 to 40,000 words a day. A lonely person who sees no one may only speak 50 to 100. So this is a way where we can meaningfully provide technology and a wearable to help reduce isolation and loneliness. What we do is the person wears it, and when they drop below a certain conversational threshold, an SMS is sent to family and friends. Also, we look at what intrinsically they can do to help them be less lonely. Because we know if we address isolation and loneliness, we can address medication adherence, we can address exercise regimes, a whole range of things. So we feel that isolation and loneliness is such a Trojan horse for a brand new model of care. So I'll finish here to make sure we've got plenty of time for a conversation. But a lonely person's future is determined by the hundreds of actions taken daily by thousands of people. Actions based on what they believe about a lonely person's future and their role in it. One Good Street gives the community a role in reducing isolation and loneliness. Thank you so much.
Thank you very much, Muti. And our next speaker is Stephen. He has a very interesting new nursing care model, which is now very international. So may I first invite Stephen to speak to us? Thank you.
Yes, thank you, Jane. I think we start with a video.
to build organizations on meaningful relationships. So I think that, especially in healthcare, it is about trustful relationships.
Now a presentation. So this video gave you already an overview on what Bürzog is, and I will go a little bit more into. That's the end of the presentation. It's the end of a presentation, not the beginning. Yeah. I will go a little bit more into the details, but before I do this, just to show you that this is not just an idea, but actually this model has created a lot of impact. Bürzog was started 11 years ago in Holland with 4 nurses, and today we have around 14,000 nurses caring for 100,000 patients with a revenue of around 400 million euro. So actually it's one of the most impressive European entrepreneurial stories, and interesting enough, nobody knows it. But that's probably also because our founder and CEO is a very humble personality. So let me go back on the concept. First of all, why did Jos de Blok, the guy in black, has had the idea to create Bürzog? Bürzog is Dutch and means Buurt, neighborhood, and Zorg, care. So it's care in the neighborhood, fits very well to your model. And he was a nurse and worked for many years in neighborhood care, but got frustrated because in Holland, like in most Western countries, care actually got industrialized. So nurses are being forced to deliver standard care items to patients. Patients get standard care, although they would prefer tailored care for their needs. And the incentives for care providers are actually to provide as much standard care as possible with as low-skilled and cheap people as possible. So costs are exploding. And he got frustrated and said, well, this can be done and should be done in a different way, and came up with the idea to create Bürzog as a nurse-driven company, basically reinventing the role of a community nurse and focusing on working in neighborhoods. The video already mentioned the 7 key factors of Bürzog, but I would like to repeat them again. Number 1 is nurse centricity. We believe that nurses don't need managers to tell them what to do. Actually, nurses know best what to do with the patient. And also, it's important to create a work environment for nurses where they are happy and proud, because if the nurses are happy, the patients will be happy. Number 2 is the focus on neighborhoods. We believe, like you, that there are a lot of resources in neighborhoods, and actually it's important to be able to leverage these resources for the care of the patients, so you need to know the neighborhood. And also, if you focus on neighborhoods, you have low travel time, so you don't waste time going from one client to the other. Number 3 is the focus on patients, or basically patients' centricity. We don't deliver any standard care. So when we first see a patient, we call it, because Dutch like coffee, first coffee, then care. Our nurse can spend 2 or 3 hours, if needed, with the patient, because we want to comprehensively understand the situation of a patient, which is not only about his health status, but also the social situation, the family situation. So it's all about understanding the specific situation of a patient before we develop a tailored care plan. And the care plan for us includes not only health topics, but of course also social topics. Number 4 is leveraging networks. And here I would like to use our onion model to explain what we mean with this. We have a client or the patient in the middle, and it's our objective to create as much independence as possible for the client again. Even bedridden people can do much more when they think, if they get the right advice and support. So it's about self-managing your clients, but then also of involving the informal care networks. This can be family members, neighbors, can be volunteers in the neighborhoods. So we try to involve them all. In Asia, also care workers, and only the 4th layer is the Bürzog team, and the 5th layer is GPs, hospitals, and whoever is needed for the care. So we work inside out, and it's about leveraging the networks. And why are we doing this? It's first of all because it's, of course, nicer for the patient, but also there is an economic reason behind it. So when we start, normally a patient is in a very bad health situation. There is some informal care already, and then the Würzog nurse needs to care a lot. But the objective is that over time, the support needed by the Würzog nurse gets minimized. We believe that nurses are scarce resources, so actually there is no use to sell as many hours from one nurse to one patient. We are striving to do the opposite. And this is not only lip service, we can prove this through facts. The Dutch Ministry of Health mandated a study from KPMG, and according to that study, the average hours of care spent per patient in Würzog are 35% lower than the market average. And we are continuing to work on this. Why are we doing this? Because of the scarcity of nurses, but also because it gives us more freedom to negotiate better rates with the insurances, so that we can also pay better salaries to our nurses and make the job of a community nurse much more attractive. Number 5 is lean management. We operate with self-steering teams. I know in Asia always difficult to understand how this works, but our nurses are organized in teams of maximum 12 nurses, and they have to organize themselves. And they have to recruit the team, they have to recruit the patients, they have to do the rostering, they have to organize their training, as if they were self-employed, but they are not. They are all on our payroll. And in Holland, it even works without hierarchy, so we have no team leader in the team. This leads to a very lean organization. This is our nurse organization. We have 10,000 nurses. We have 21 coaches and 2 managers, and around 50 people in the back office. So this is, of course, not only nice to talk about, it's also a very big advantage in terms of cost. So if you have such a decentralized organization, you need something to keep it all together. And so we use an IT solution which we developed ourselves. Basically, each nurse has an iPad, which is her core working tool, and she uses it for everything, for the rostering, for the entire care process, from assessment to developing the care plan, to planning the interventions, documenting the care, and also measuring the outcome. EHR, billing, training, everything is done with this IT solution. And it also helps in a very decentralized organization to ensure that we have basically an alignment in the way how we work. And number 7 is standardization. So you saw our founder, Jos de Blok, in black. This is how he is. He believes it's unnecessary to have complexity with dressing. So he has only black clothes, saves some time in the morning in front of his wardrobe, but also when he does his shopping, he always buys the same, black t-shirts, black trousers, black shirts. And this is the way how he thinks. Whatever is not client-facing can be standardized. And that's the explanation why we can operate a back office of 50 people taking care for 14,000 staff. So you can only achieve this if you standardize consequently. And the result of this is that our overhead costs in Holland are 8%. Market standard is 25%. And we use the saving, because we are a foundation in Holland, to pay better salaries to our nurses and also to give them more freedom what they do, so they don't have to achieve such a high productivity. So if they think it's important to spend some time in a community, they can do it. They have the freedom to do it. So results, happy nurses. And I mean, these pictures, of course, are nice, but whenever I come to Holland, I can tell you, you always meet happy people. It's really impressive. And also happy patients. This one is 104, so it's older than your Vera. So right now, this was a 100th birthday. And basically you can say the nurses are very happy, which can be seen that Würzog was chosen a couple of times as best employer of Holland. The clients are very happy, and most important also the payers are happy. Actually Würzog helps a lot in the Dutch system to save cost and also to focus the available funds to the right things. So rather than spending money on bureaucracy, we spend money on the patients and the nurses. it started with home nursing, but meanwhile we have also a lot of other activities which are managed the same way, like youth care, like psychiatric care at home. This is physiotherapists. We have hospices. We have home care. So all type of business, you can apply the same model to those. Well, Jos de Blok got many awards for what he's doing. There are many books written about him. So actually, he was surprised by his success, and he never intended to do anything beyond Holland. But because of his success and all the interest, he said, well, maybe we should also start to do something internationally. And so 5 years ago, he started to go international. Meanwhile, we have projects in more than 30 countries. And for Asia, we set up a company, Buurtzorg Asia, based in Hong Kong, as a social enterprise with the idea to bring the Buurtzorg model to as many elderly as possible in Asia. We have own legal entities or operational entities in China, Japan, Taiwan, and India. And the good news is yesterday night we signed a contract. So we will also start together with a team of very committed and dedicated nurses here in Hong Kong, probably starting in June. So I hope you will see this as positive news. Of course, we cannot take the model from Holland and just implement it in Asian countries. We have to do a lot of adaptations, but I mean, we are not dogmatic. It's not about the model, it's about the result. I mean, we want to have happy nurses and happy patients and affordable cost for care at home. So I don't want to go through all this list, but the key message is that we are able to adapt the model to the specific situation of each country and especially the elderly and the nurses in each country. So that's, I mean, we are still a startup. After the first 4 years, a lot of challenges. We are now in 4 countries and we care for around 4,000 patients. The ambition for this year is to achieve 10,000 patients. As I said, we are a social enterprise. We have no financial targets. We only track the number of patients we care for. And I hope that in 2020 we will be proudly presenting that we also care for many elderly in Hong Kong. Thank you.
Thank you. Very good to know that Buurtzorg is planning to start in Hong Kong, and we look forward to meeting with your team. And before we have the discussion, let's have the third speaker first. Dr. Wu To, and his organization is called Tazuyu. And I understand you are trying to explain to us the Japanese model of care. Thank you.
Thank you. It's an honor to be here. So I'm a cardiologist and a home care specialist. So we have been seeing over 5,000 patients in total at home care setting. And I studied some ventures in Japan and in Singapore. And at the same time, I'm having the advisor for the Ministry of Health, Ministry of Economics, and Ministry of Communication and Diet of Japan. So today, I want to introduce how the government of Japan is tackling with super aging problems. And I hope it will be helpful to you. So I think you are familiar with that kind of figure. So we are proud of the number 1 aged country in 2015. So we are in the super age society, meaning the aging rate is over 21%. So from country-wise, Japan is number 1 and Italy, Germany. But what's the landscape will be in 2060? So this is a figure. Oh, by the way, so Minister of Economics kindly share their slides with me. So now Japan is in a super ultra-aged society, meaning aging rate is over 35%, meaning one of the third is over 65 years old. But Japan is number 1, but Korea, Taiwan, Singapore, Portugal, Poland, Greece, and Hong Kong is number 9. So it means that most of all the countries are aging. So, and you know how many numbers of people, Japanese, are over 100 years old. It says 70,000. 70,000 Japanese are living over 100 years old. So the government of Japan is now seriously thinking how to tackle the problem, because I'm supposed to live over 100 years old, according to them. So we need to think about how we can spend the life. So it's a very interesting figure. So it's a 250-year-old data. So it's 1868. It's the start of modernization of Japan. And in these 250 years, the demographic is changing so dramatically. So when you see in 1868, the age between 15 and 49 is here. And this is below under 14. And we have very few number of aged people. And it's changing and changing. But you need to think about, this is an end of bubble economy in Japan, but you need to think about in this era, around 1970, the social system, the current social system was established at this time. And you see that a huge change of demographic since then. So we need to think about how to change the social system, of course our financing system, to meet this age. But you need to think it's a kind of reverse, right? So previously we have a lot of young people, and almost at the same ratio, we will have over 65 years old. But the number of over 65 years old ratio will not change. So the government of Japan is promoting the concept of a hybrid society. The meaning is a combination of productive age and second social activity period. So I'm going to talk later how the government is tackling with them, but you need to think about, as the two previous speakers mentioned, but how to create opportunities to enable participation in moderate economic activities, because they cannot work so hard, but still we need to give them the opportunities to work or to participate in social activities, even they get kind of dementiated. So this is a very important concept, creation work, and they need to have some social role. So I'm just briefing Abenomics and healthcare innovation. So it said that Abenomics accelerate healthcare innovation, and there are three targets. One is integrated and store personal health records. So I think that Hong Kong is doing that kind of things, but we are going to introduce more and more to promote integrated personal health records. People can carry their medical information on their, say, apps. Second is enhance remote medical care services. So the last April, we introduced the telemedicine officially, meaning the connecting the doctors and the patient will be reimbursed by the government. And third is, of course, use AI and robotics at the long-term care facilities. So telemedicine. So as I mentioned last April, so newly assessed telemedicine, meaning connecting between the doctors and patient, is first reimbursed in the history of Japan. So it's a very big change for Japan, because Japan Medical Association has long been against the introduction of telemedicine, but finally we introduced. Second is that we are going to assess AI or other technologies in terms of reimbursement. So it's coming soon. So how to introduce AI is a big issue in each country, because it has a lot of problems. But we decided to introduce AI-supported medical devices in 2020. So this is a system. So I developed a system called YADOC. So YADOC is a cloud system which enables questionnaires or telemonitoring or teleconsultation between doctors and patients. So the patient can send their information via Apple Watch or a smartphone, and the doctors can see the trend even they are in a remote place. So now we are going to use IoT, meaning we are working with some pharmaceutical companies to introduce an inhaler sensor device. It's just one example. For example, if the patient COPD or has asthma, so they need to use an inhaler, but nobody knows how often or when they are using inhaler in detail. So with IoT connected inhaler, we can understand when the patient are using the inhaler. And our system also can gather the information from EMR and the patient's symptoms and so on. So for the first time, we can know the very detailed and maybe ongoing data from the patient and doctor side and can align the two data. So our system is already installed in 1,600 institutions, and now we are going to gather the information to meet the data. So robotics. So it's a very messy chart, but I'm sorry about it. But the concept is that now Ministry of Health and the Ministry of Economics are working very close on how to introduce robotics. And I think there are two types of robotics. One is for communication, and second is for more on support for human. And the government is now focusing on helping the people to support the patient. There are five areas. One is patient transfer assistance. As you know, the caregivers have a lot of back pain when they support the patients to move. So we are using some kind of attached robotics to help the caregivers to carry the patient, or maybe a mobility assistance. So we need we are now developing some kind of a small devices which enables the patient or people with weak legs can move swiftly. And third is toilet assistance. So people do some miss when they going to toilet. So we are developing some devices that people don't miss toileting. Fourth point is protection of patients with dementia. That we are using a lot of sensors, monitors to help the dementia patient to live in a normal way. Last is a bathing assistance. So anyway, so we are doing a lot of pilots in Japan how to introduce robotics. And new technologies, I'm just going to introduce three cases. One is deep-free. So now caregivers have a lot of problems when they see the patient who have incontinence. So this is a kind of ultrasonography. You can put the ultrasonography on the patient's abdomen, and it can detect when they are doing urine. So the caregivers can predict when they should bring the patient to the toilet. Second is VR-assisted rehabilitation. So the patient can wear that kind of VR device, and it can help the rehabilitation. So the devices show that how you can move your body for better rehabilitation. And third is it's a very small sensor, but it can detect how your brain is working. So you know the physical fitness, but it's said that it's a brain fitness, meaning when you do something, how the brain is working, it can monitor it. So, okay, for you, the reading is more promising or maybe is effective. But for some others, maybe walking is more effective. So you can detect how your brain is working with just putting some devices around your head. So the concept is how to know what's the most effective way for rehabilitation with these kind of systems. So this is just a very few examples, but we have developed a lot of more and more these kind of devices to introduce the field of medicine and healthcare. Last is prevention. So we are using a lot of course, welfare costs in Japan. It's huge amount. It says about 2 billion Hong Kong dollars per year. And it said that 1/3 is spent for lifestyle-related diseases, hypertension, diabetes, and so on. So how to reduce the cost, especially related lifestyle disease, is very key. The government of Japan is introducing the concept of health and productivity management. It's for employees of the companies, meaning the government is supporting the companies who are investing in the employees' healthcare. The concept is if you invest in employees' health, then of course, there are some health promotion of employees, and it will improve the employees' vitality and productivity, and finally, it will have a positive impact on the company's, say, value and performance. So this is a last slide. So the government is introducing some award system for large organizations. They pick up 33 companies who are doing well for the healthcare management of employees, and 500 the second layer. And then they expanded the concept to SMEs. So this is a very good concept, and that we now have data that better health management companies have a better performance in finance. So that's it. And I'm happy if you have some hint from what the government of Japan is doing recently. Thank you very much.
Thank you very much. Now, we have very quickly listened to 3 presentations. Dr. Maju is from the medical background, and Maju is from nursing background. You're from business, or you're from business background? Very different approaches. And of course, we all need a very integrated approaches in handling our aging problems and medical need of our aging population, isn't it? So before we have the questions from the floors, I wonder whether the 3 speakers, particularly Maju, whether you want to elaborate a bit further before, or respond to other speakers before we proceed with the discussions?
Absolutely. I think when we talk about ultra-aging societies, we have to think of aging and responding to aging outside our own sector, which I now think of a marketplace of care, which includes policy, but really radical policy, and policy that gives companies tax reduction for investing in aged care. And also we spoke before about individuals getting social credits, that individually, if you do things for older people, so if you just think about behavioural economics and what motivates individuals and then what motivates companies, we have to look at very new, innovative ways of giving tax concessions for those that are involved in aged care. And for those people that do great things for older people, that they get tangible reward. And that includes large-scale tax concession for big companies for investing in supporting aged care, because we know it's unsustainable. And the slide of 2060 with those numbers increasing, it can only be funded if we radically look at the economics of it.
Right, and I think the interesting point of your model is that you encourage neighborhood and volunteer involvement in supporting the aged people, and that is a combination of social and nursing care.
Absolutely.
Right.
I think we can't do one without the other anymore. And often when I present, the nurses and doctors just think about just more of themselves. Let's get another nurse coordinator. But really there's we haven't really leveraged the capacity of the suburb and the desire of the suburb. So the 500 volunteers that work with me, most of them are trying to redeem the experience of aging which they had with their parents, so that they're unsatisfied with how their parents were treated and they don't want others to go through that. So there is this untapped motivation to diversify and democratize care beyond the clinician. A lot of my work is trying to get clinicians out of the way, because clinicians often insert themselves in when they don't need to be. And that beautiful diagram with Burzog, which means less nursing hours and more of through the reablement model, means that we develop tools with their family members to do so much more. Family members can develop a care plan. Neighbours can develop a care plan.
Right.
Don't have to be a nurse to do that.
Okay, thank you. And Stephen, would you like to elaborate a bit more or respond to the other speakers?
Yeah. First of all, I saw already many charts from Japan. It's the first time I saw 2060, and also this chart where you compared the development over 250 years. It's very impressive, and I think it's a chart which should really call for action. I'm sometimes rather frustrated to see how little awareness also among government is that, it's not about talking about the aging population, it's about doing things. And I think your chart, I really love it. Yeah? So I hope I may steal it with pride, because it's very powerful. Another aspect I think was quite striking. The three of us never met before. And we have very different areas on which we focus. But imagine if the three of us would work together. Your neighborhood network would make the life of our nurses so much easier. Your technology, the same. So I think it's also about, luckily, conferences like this exist and bring us together. There are so many good ideas, but it's also a challenge to bring them together and make them happen.
Okay, thank you, Stephen. And Dr. Muto?
Thank you very much. So the presentation by the two guys are very impressive. So I have a question, because in Japan we are facing a shortage of any caregivers or doctors and nurses and so on. So can you share how to find the best mix of sharing, spending time to the patient, but at the same time you need to have some productivity. But sometimes if you chase productivity, it may decrease the motivation of the people. So how to balance the productivity and quality? So we are facing that kind of question.
Yes, I fully agree, because actually we are in Japan. As an outsider, sorry to say this, but I have sometimes the feeling we are in a hamster wheel. Every year in Japan, 2,000 new community nurse teams are established. Sounds great, but 1,800 are terminating. Yeah? So basically, always new teams, and the only way how they can set up a new team, because there's a legal requirement to have 2.5 full-time employees for a nurse station to be approved, is to hunt the nurses from the other nurse stations, and then they have to close down. That's not a solution. And we believe, and the same actually happened in Holland, that the solution is first in minimizing the care hours per patient, but at the same time, if needed, give the nurse the freedom to provide quality time for the patient. And this is not the case every day, only sometimes. Yeah? And the second thing is how to mobilize both nurses and also former nurses and young people to take the profession of a community nurse or a home nurse. It's a very unattractive profession in most countries. It was the same in Holland 11, 12 years ago. Today, it's the other way around. I mean, young nurses actually are keen to join Bürzog and not so keen anymore to work in hospitals because they love the model. They like the autonomy, they love the flexibility of working hours. Many of our nurses are mothers, and they work maybe something between 10 and 25 hours. You couldn't organize this if you have a central staffing pool, but if you delegate it down to the individual team and tell them, okay, you have to organize that it works, and you decide how many hours each of you has to work, then you can make it happen. So we think it's all about creating an environment for nurses so we can attract more talent back into the market or also young people to enter this market.
So each of the team is free to work out the number of hours or the number of patients that they are serving?
Yes, I mean, basically, of course, I think they have to agree it once a month. They basically have to commit, I will work next month this amount of hours, yeah? But it can be any number. It can be 17 hours or 32 or whatever. And then the team has to figure out how to take care for the patients. Yeah? So it's very flexible. Yeah?
And Dr. Muto, could I ask you a question? How you would like to respond some of the emerging model, which is a kind of attempt to integrate medical and social services together. And yours, of course, is basically very much focused on technology-based medical advancement. So what is your view on medical-social integration?
Okay, medical integration. First is maybe the effectiveness, meaning that, for example, in Japan, a lot of the hospitals thinking that the medical data is belongs to their own. So a patient don't have the power to own their medical data. It may be same, I'm not sure. So if we want to integrate the medical data or healthcare data for a better analysis or better services, but there's no way to combine and integrate the data. Also, of course, the government are trying to achieve it, but some vendors are having against, so they don't want to share any information outside the system. So my concept is that I want to make a good PHR system. So I'm now working with many vendors to share the information with our system. And on our system, the patient can carry the information by themselves and giving the data to us, and we can giving them back after analysis how to get the better services by themselves. So I want to make the consumers or patients a key player to select and have better services by themselves. So to achieve this, you need to integrate the medical data and healthcare data, I think as you do. So
Okay.
this is a main purpose.
Sure, thank you. Okay, I wonder whether there are any questions from the floor, from the audience. Yes, please.
My question is to Mr. Bush, and I am interested to know how to recruit a big group of volunteers. You got 500, right? And how to keep them, and how to do they need some kind of training before they actually provide service to the elderly?
Great question. We look at what already exists within a neighbourhood. So you might find if you've got a particular region you're working in, just use the groups that already exist, and then you are really just cross-pollinating, because we don't want to steal volunteers from anyone else. Because there's like this group is doing something for like Meals on Wheels or food. This is the garden club. So we're not there to poach volunteers. What we're doing, 2019 means volunteerism has to be very, very different. And people are wanting variety and choice and experience. So we really focus on the volunteer experience. But I would be, from starting out, I would be using your local neighbourhood network groups and then you've got to provide something valuable for them that they can take away, and think hard on how you can reward them. Now, none of us can give them a whole lot of cash because there's no cash, but you could do something like reward their street or reward the suburb, because you're looking at how to, I suppose, work on that social renewal and that urban renewal movement. So that's the sort of stuff we've done, and we've been highly successful. With that 500 group on Facebook, we push out content about dementia, about how to look after elderly, lots of inspiring stories. So they're actually becoming more informed. And one great thing they speak about is that once they join One Good Street, they can't unnotice the older people in their neighbourhoods. They see them everywhere. You see a walker and you start to think about that older person in their lives. So it does create a movement where they start to value those individuals. So I'd be leveraging off everything that exists already, and then thinking very clearly and sophisticatedly about how to reward those volunteers for their involvement. Now, also, you don't want them for a long time. Volunteerism has to be porous. They can come, they can go. If they give you 3 weeks, great. I'm a Rotarian. If anyone else is a Rotarian, if you don't volunteer, like everyone's upset about you because you didn't volunteer. That is not the value proposition for volunteers in 2019. If they come, fantastic. If they go, great, come back when you're ready. Dip in and do something today, and then maybe do 3 things next week. But you've got to at least provide them with about 10 different options, because then that's attractive. And then they need to use that for their own social world. They need to post it on Instagram. They need to post it on Facebook. Like, we're constantly looking for ways to reward them with their social reputation.
So how do you overcome this problem of instability of the kind of services provided by the volunteers?
We look for new ways of connecting. So, for example, the bike that I showed you, that we take older people out for a bike ride, we partnered with a gym, a CrossFit gym, because CrossFit people and people who go to gym are mad for burning calories. They just want to do exercise all the time. So we use different partnerships like that. So it now is a social proposition. It's a value proposition for that gym to be involved. The other thing is to leverage off the post people. So our post people that are delivering mail, so partnerships that aren't connected. And we've seen that in France and in the UK, where the post people go and spend time with the elderly to reduce isolation and loneliness. So that provides some kind of stability of a pool of people for things to do. But you don't always get enough people to do what's required. That's just a reality.
Sure, of course. And would you mind telling us what is your financial sources?
So we beg, steal and borrow, and really $20,000 is all it's taken to do all of that work that I've done, and we're active in 4 suburbs. So government grants and whatever cash someone is giving away, I'm writing grants all the time. But I actually, this is a bold statement, we don't really need that much money, and I want local government to stop giving money away in an uncoordinated fashion. So currently in suburbs, they will fund a garden club here and an elderly exercise group here and cardiac rehab over here. None of it's coordinated to health outcomes, so they should really stop this clandestine, indiscriminate funding mechanisms for a range of activities and start to have a more coordinated approach. So that's what I'm advocating. I don't want government actually to give us any more money until we get ourselves together and organise ourselves better, because we are a disorganised hot mess in the community, and it's about time that we started owning that we are failing the older people because of our inability to work cohesively together.
Okay, thank you. And other questions? Yes, please. Is it possible to give her a mic? Thank you.
Thank you. Actually, I want to go back to the nursing input to home care services because I'm a nurse. And actually, nurses shortage has been a worldwide problem. But I don't think the nurses shortage should stop the development of quality home care in the community or compromise the quality for home care in the community. So I have the experience in the past 5 years to run a private company on home care with a professional model, with a professional nurse-led model. How I work is quite similar to Holland's experiences, is that because the nurses are expensive here, and then we have shortage, so I try to put up a sort of a pool, a freelance nurses pool because nurses are undergone a lot of specialty training with a community care commitment in the training. So I got all these people with qualifications. So I try to recruit them into my freelance posts with different specialty background, but they are not my permanent staff. But I have to motivate them from time to time because they are part-time nurses, right? So I pay them only when they are required by the patients, by my clients. So it helps to improve a cost-effective model. I don't have to, set up the full-time nurses in our center, but I do use experienced nurse manager or nurses in the center to overseeing all the quality. So each care team is being headed by a specialty nurse, whether they are a stroke nurse or any other cancer nurse, whatever. So it will be headed by this specialty nurse, and then he or she is supposed to be responsible for the care standard, doing assessment, implementation, etc. So, and in the team, there are other nurses associates, the auxiliary people. But they appoint whoever to work in the home care is the case nurse responsibility. Mm-hmm. So it works out well. And I think Hong Kong people, Hong Kong public, the families, they have to adapt to this. Because at the very beginning, they give me a call and say, oh, don't give me nurses. They are so expensive. I just only want whoever, a domestic helper, etc. But that is not the case. We don't want to compromise the quality of quality care. Yeah. So we use nurse, and only with very, very limited time, but they have heavy duty and accountability to it.
Yeah, sounds to be a very, very good model. So happy to hear that it exists. I think that the challenge probably is the scalability. Yeah, if you look at Hong Kong in general, I'm surprised again as an outsider to see the high percentage of institutionalized elderly. It's the highest percentage in the world. If you see the figures, it cannot continue like this. So I think Hong Kong needs a scalable model, but I think what you do could be the starting point of a scalable model. And I also like it much more because there are, as you know, many platforms like Uber trying to match care needs with carers or nurses. The challenge those platforms have is it's not continued care. So there's nobody continuously responsible. And the quality of care is very difficult to manage. So I like your model where you have one nurse, one case person in charge to ensure that the quality is the right one.
Okay, thank you for the question. I think we have 2 or 3 more questions on the floor, please.
Okay, thank you so much for the sharing, and especially I learned a lot from all of you. From the perspectives of general technologies developments, I have questions on that. And I know that there are a lot of different kinds of technologies are currently being developed or is developing. From the perspective of how we can using that in other countries using them in other countries or internationalizations, is there any research things that we can do in order to select the things that is fit for our Asian countries' context? So, from Dr. Mutos, you have shared a lot of different kinds of products in Japan. Do you have any recommendations on how we can select those international products that can be adopted in our own Asian context? Or the other guests, you can also feel free to share. Thank you so much.
She's asking, how to make the choice for adaptable to Hong Kong and Asian context.
Thank you very much for the question. So we are studying the business in Singapore and expanding in other countries. And from my experience, anyway, it's not so easy to expand any technologies to any countries. So you need to know about what the social system, especially reimbursement system. My experience is that if the medical device is not covered by national insurance, it's very difficult to expand and for the most of people to use it. So this is from, say, reimbursement system perspective, but at the same time, you need to know what's the exact needs for the people and patients, including professional providers. So in Japan, as I mentioned, we are facing a shortage of caregivers and professionals. So a lot of robotics is now being developed under this pressure to meet the shortage of the people. And as she mentioned that in Hong Kong, I think we are also facing the shortage of nursing. So it's I think as a startup, we always taught that you don't need to go to vitamins, but you need to make painkillers, meaning that you need to exactly know what the dead needs. And otherwise, the market is not so big, or you will fail in the business market. So in that sense, you need to think about what the Hong Kong people deadly want, and in terms of, say, a shortage or maybe quality, productivity, whatever. And you need to find a niche market at the beginning. So you cannot expand a business all in the country. So you need to find niche needs which the people deadly want, and then you can start from here.
And it seems that if we could also adopt some robotics or technologies from overseas, we could also conduct research with the universities like what you're doing to make it an evidence-based kind of adaptation and availability for the local market, isn't it?
Can I just add to that is
Yes,
the
please.
the need for each country to have a discussion around ethics in AI and also privacy in AI. So, for example, in Australia, and if we went down that corridor there and if we purchased all that tech, that's all of our data leaving to a range of different sources. But also, it's absolutely fatiguing the amount of SMSs that our families could be getting if we were fully teched out. And you go into people's homes where they have not got any evidence and have purchased a range of technology, and you look at the adult children and they're exhausted because their phone goes off most of the night every time their mum and dad gets out of bed and wanders about. So there's a real need to curate the technology, but also to have a conversation about what are the ethical guidelines in Jerry technology for artificial intelligence for Hong Kong. What is your social tolerance level for all of the data of your older people being owned by companies? And this is a conversation as a parallel process, and colleges and universities developing these ethical guidelines for artificial intelligence so that you feel comfortable and confident in the technology. One thing, our nurses are rare to promote any technology because they love their model where they get up and see all their list of clients. And the technology should inform where their focus of effort should be. So there's a real difficult conversation to have with those nurses around you can't just get up and see your list because the data from the home should be informing who is most likely to deteriorate, and that's where your focus of effort should be because we're outcome driven. And at the moment we're just early in that conversation with that particular group.
Thank you. Yes, sure. Do we have one more question? Okay, this lady first. I noticed there should be a hand right now. Okay, I'll come back to you. Yes, please.
不好意思，我不会那个英文，然后我用广东话还是用中文比较方便一点。
我帮你翻译吧，没问题。
OK， 那我首先是想问一下那个布什先生，他这边的话就是在做这个项目的时候，因为我在大陆也是在做这个养老的策划的嘛，然后我们面对的问题就是在这种互助型的养老的情况下的话，就是现在大家就是包括长者和服务人群，他都会有一个相互的怀疑。就是老人会怀疑说来照护我的人他具不具有这样的专业的能力，然后照护的人他也会担心，如果在照护的过程中，就哪怕是义工，他也会担心说在这样的过程当中他会不会承担什么样的责任。所以我想问一下，就是在布什先生他在做这个项目的时候，遇到这样的问题的时候，他是怎么解决的？然后另外我想问，
我先帮你问他好不好？等一下我再回来。你是有2个问题吗？
是还有 有一个我想
好的，
问
等一下我再回来。我先跟你问这个好吗
OK，
好，
谢谢。
谢谢。This is the first one is for Mr. Bush. She is from China mainland, and they're providing elder care services. And she wonder whether there would be skepticism by the elders who are taken care by the volunteers. That is possibly what's happening in mainland China. And she's also worrying whether the volunteers would be concerned about the kind of legal liability that they have when they provide the volunteer services on a home basis. Right.
So we need insurance for our volunteers, yes. And it also, we have to test those assumptions. Many people care for their older neighbours already. So therefore, they're already doing it. So there's a comfort and a tolerance level in the community for having your neighbours care for you, look out for you. There's more a scepticism amongst nurses about how unsafe volunteers can be. But again, we have to test those assumptions. We don't have a choice not to test them, given the avenue of ageing and skill shortage we have. So yes, we must train our volunteers. That is all achievable. That is all achievable if we break it down and provide support for our volunteers. But there is a potential to, if we look at pulling off a good experience each time we do it, that builds the trust. But there has to be an attention to what is the experience like of having a volunteer come in and cook you a meal and then stay with you and eat the meal with you. If that's a good experience, that then gives them confidence for the next volunteer. But remember, we do this in conjunction with community nurses. So the community nurse is the trusted provider, they're the trusted person, and they refer to us. So really, my job is not to convince the patients or residents or clients, it's actually to convince the nurses to trust us to do it.
You have the nurse as the focal point.
Correct.
Isn't it? Right. Okay. And 第二个问题是给你 just for you.
就是武藤先生的，我可以用日语问他吗？
可以啊。
OK。
Okay.
すいません。ちょっと質問したいんですが、日本にいた時はいろいろのそういう技術の医療商品を見たことがあるんですが、でそういう商品見る時はやっぱりいろいろ調べたらコストがすごく高いんですよ。でこれは日本ならで医療保険で引けるんですが、で日本の会社とか普通の人間普通に使えるんです。でも例えば海外に使うとそのコストは一般の施設とか使えないんですよ。そういうコストは普通に経営する時にも結構大変ですが、でこういう機械購入するともっと大変になるんです。例えば今日本はアジアって技術すごくトップの国ですが、でそういう技術はアジアの皆さんに一緒にやることができるかどうか、そのルートがあるかどうか、今日はちょっと質問したいんです。我自己说吧，我就是问一下他，因为他们日本的这个产品的技术是蛮高的，但是它的成本是非常高。如果是说，因为他在日本的话，都是从他的养老保险里边直接就由他们的就是保险里边就可以走了，所以一般的人、一般的这种养老设施都是可以去使用的。但是刚才大家都很想知道，这样的经验可不可以分享给就是亚洲乃至世界的做养老的同行？那我就想问他有没有这样的途径，就是从成本控制上面能分享到没有保险能够去支付的情况下，大家也能够去使用的这样的途径。OK， ありがとうございます。
So please.
Okay. Thank you very much. So I'm going to answer quickly. So you are asking, you are talking about the cost of medical devices or robotics, and it's very hard for to use that kind of devices outside Japan. But okay, my question is that even in Japan, it's very difficult because it's expensive anyway, and most of them are not covered by national insurance. If the devices can show the clinical outcome, and it can get a certificate as a medical device, and sometimes reimbursed, but it's not so easy way. So in that sense, many robotics developers have facing the same challenge. And in general, the people cannot buy. So for example, medical institutions or nursing homes can buy it. but it's not for adding value in a sense, but it's more on how to reduce the shortage of human people. So it's a very big incentive for medical institutions or nursing home to purchase some devices. So, and outside Japan, I'm not sure because it's very good and sometimes it's very variable, but people may not purchase it out of their pocket. Yeah, you're right in that many developers are facing that kind of problems, even in Japan.
Okay, thank you. In view of time, I think we have the last question from the lady.
Hi, interested to know some of the invention. My job is to help elderly to age in community, and Mr. Bush mentioned that they with the booth, and you can help them to have this even if they drug compliance or we can medication compliance. So can you explain more how can be achieved this, and maybe the other two speakers can help out how to help the elderly to have the medication compliance or drug management so that they can age in place.
Sometimes we cause toxicity in medication because the person's been taking maybe 70% of the time, and then our nurses come in and make them take 100%, and then they have to go to a hospital because we cause toxicity. So I think, yes, there are a range of sensors that can tell us whether they take their meds, and there's a range of devices. And even our brooch that counts the number of words, you can make it a false monitor. There's a range of things we can do. I think one of the latest developments is the pharmacogenetics and doing the DNA testing to look at what particular medications are appropriate and then try and get them off. Anyone over 5 medications, I would be encouraging to have the DNA sequencing. It only costs like $100. And then you work with the GP or a pharmacist to reduce the amount of medications that they're on, because you know what it's like. You go into a hospital, they prescribe you something. You go to your GP, they prescribe you something for what the hospital prescribed you because you've got side effects from it. And it continues. And then, of course, they take all their own complementary medicines. So you're ending up with 15 plus medications. So I would be doing DNA testing and then a program that reduces that. And using volunteer networks to do the medication reminders seems appropriate, because we pay nurses to go into somebody's house. Like that photo of Vera, she had a glass of water there because we paid a nurse $80 to walk in her house and watch her take medication. What a waste of time of that nurse's time. And also, certainly, there's other ways we could improve that compliance. I think compliance improves when you start to give older people more choice in their life. Older people resist our persuasion to be more healthy because they don't buy into the version of their future that we have. So it is imperative for us to discuss with an older person, what are your goals of the future? And maybe it's not to be healthy. That's uncomfortable for us because we all got out of bed to make sure everyone's as healthy as possible. But there's tolerance level to allow people to have a future defined by them, which may not necessarily mean taking all of their meds every day or never falling. For example, we're obsessed with stopping everyone falling and then giving them a whole lot of monitors and making their house unlivable. If they want to dance the tango and fall at 87, let them. It's the dignity of risk here. And I think that's worth thinking about as we start to move between, when we talk about healthy aging, it can be a really narrow term of these super fit masters athletes who are 97. That's not going to be everyone. It may not be what you and I want. I want to be eating green tea ice cream and drinking Pinot Noir till my last dying days, which may mean I not do any exercise whatsoever and may not take any of my medications. And that's successful for me, which means our models of care have to find a way for us to champion that success. Thank you.
Okay, thank you. And the other two, Stephen or Dr.
Yeah, maybe just one sentence. I think it's a core task for our community nurse to find a client-specific solution to this problem. And it can be very different. We also don't believe it should be done by machines. It's about education of the patient, family, involving neighbors, whoever. But it has to be an individualized solution, and we don't want to spend nurse time on this in the long run. Yeah, so it has to be at the beginning, but then it has to work somehow by itself. Yeah?
All right, thank you very much. And at this point, I think we should finish because time is up. But once again, thank you very much for this free speaker. excellent presentation. And I agree with you, Stefan. Three of you should work together, but please include me when you are really working together.
Yes.
Okay.
Thank you.
All right. Thank you very much. Thank you once again. Bye-bye.